Kanski lecture series Conjunctiva part 5, and today we are going to discuss about the conjunctivitis in a blistering mucocutaneous disease. So what is a blistering mucocutaneous disease? Basically in which there is an antibodies that are formed against the mucous membrane, like for example, this is an epidermis and the dermis, and there is there are antibodies that are formed and that are not allowing the epidermis to connect to the dermis, and which causes the blistering effect, and that can avoid the cutaneous region, that is your skin, and mucous region, that is your oral uh, mouth region. And when it also affect the eye, it is called it can also affect the eye. It causes the conjunctivitis in a blistering mucocutaneous disease. So let's discuss about that. So first is the mucous membrane pemphigoid. Mucous membrane pemphigoid, also known as ocular cicatricial pemphigoid (OCP), comprises a group of a chronic autoimmune mucocutaneous blistering disease. An unknown trigger leads to a type 2 cytotoxic hypersensitivity response, resulting in an antibodies binding at the basement membrane zone. The activation of the complement and recruitment of the inflammatory cells, with localized separation of the epidermis from the dermis at the basement membrane zone and subsequent progression to scarring. Studies of the HLA typing have found an increased susceptibility to the disease in patients with HLA-DR4. The HLA-DQB1 allele is particular. It shows a strong association with OCP and other forms of a pemphigoid disease. So, as I told you earlier, basically you know that there is an epidermis and there is a dermis, and there is a basement that connect each other. There is a basement membrane zone that connect the epidermis to the dermis. When the antibodies are formed against this basement membrane zone, and there is a recruitment of the cellular components and inflammatory cells, it causes the separation of this epidermis and the dermis, and this type of reaction is called type 2 cytotoxic hypersensitivity, and it causes the blistering effect, and the most of it is usually related to HLA-DR4. A wide range of epithelial tissue can be involved, including the skin and various mucous membrane. Particular clinical forms of the mucous membrane pemphigoids tend to involve the specific target tissue. Bullous pemphigoid shows a predilection for skin, and ocular mucous membrane pemphigoid, also known as ocular cicatricial pemphigoid, involves the conjunctiva in the majority of the cases and causes progressive scarring cicatrization. The disease typically present in old age and affect females more commonly than males by a 2:1. Other causes of a cicatrizing conjunctivitis include Stevens-Johnson syndrome, trachoma, drug-induced trauma, severe and chronic conjunctivitis of many types. MMP should not be confused with pemphigus, a distinct group of disorders. So basically, a cicatrizing disease is basically a scarring disease which causes the conjunctiva to become a scarred. And what such condition can are associated with scarring of the conjunctiva: Steven Johnson syndrome, trachoma, drug induced and severe chronic conjunctivitis. Ocular features: diagnosis is principally clinical, but biopsy of the involved mucous membrane often shows a supportive changes. Linear antibodies and complement basement membrane zone deposition. Progression can be divided into stages as follow. So remember, basically this is a diagnosis of the clinical entity. The patient may present the blister in the skin or in the mouth, and you can also present with the ocular features as well. And how do we suggest the ocular feature? There is a classification system that is determined, and it is a stage wise progression. That is a Foster classification system. Stage 1 is an early stage associated with chronic conjunctivitis, tear dysfunction, and subepithelial fibrosis. So, in this case, the patient present with a conjunctivitis that is chronic, and the patient will have a dry eye because of the tear dysfunction and subepithelial fibrosis. Stage 2 is the pharyngeal shortening and particularly inferiorly. Stage 3 is a semblafron formation, and stage 4 is a surface keratinization and a cicatricial ankyloblephron. So basically, what is this is basically all the changes that is occurring due to the scarring effect of the conjunctiva. The fornix becomes short, so when you pull the eyelid you cannot pull it so much, rather when the normal you can pull it for some extent, but in a case of a fornicial shortening you will not be able to pull the lid downward. What is a symblepharon formation? Symblepharon formation is basically when the palpebral conjunctiva gets attached to the bulbar conjunctiva and it causes unseparable. So this is a symblepharon formation. And what is ankyloblephron? Ankyloblephron is when the eyelids are attached together by a tag. Then this is called ankyloblephron formation. Insidious or relapsing, remitting, non-specific bilateral conjunctivitis, misdiagnosis, dry eye is common conjunctiva. Papillary conjunctivitis, diffuse hyperemia, edema, and subtle fibrosis. Fine lines of a subconjunctival fibrosis and shortening of the inferior fornices. Symblepharon is a plural symblephra formation referred to the adhesion between the bulbar and the palpebral conjunctiva. So the sequence is same, that first there will be the conjunctivitis which will be the papillary in nature. There will be the diffuse hyperemia and subtle fibrosis. And next is that there is a shortening of the fornices. So basically, and the next is that the symblepharon formation is basically when there is a adhesion between the palpebral and the bulbar conjunctiva. Necrosis in severe cases may result flattening of the plica and keratinization of the truncle. So you know that this is an eyelid, and in the eye this is a cornea, and there is a truncle in it. And keratinization means that it will become it is usually mucus in nature, but it will become keratinized and skin like changes in it. And it will and a plica will become, which is semilunar in shape, will become flattened. Dry eye due to the destruction of the goblet cells and accessory lacrimal gland and occlusion of the main lacrimal ductules. So why there will be the dry eye? Because the lacrimal gland and the accessory lacrimal gland ductules become destructed. Monitoring should include the measurement of the fornicial depth and the noting the position of the adhesion. Eyelids is the aberrant trichiatic lashes, chronic blepharitis, and keratinization of the lid margins. So the lashes will become directed inside the eye. There will be the chronic blepharitis and keratinization of the lid margin. Ankyloblephron is the adhesion of the outer canthus between the upper and lower lid. And next is the cornea. Epithelial defect associated with drying and exposure. So with the drying and exposure there will be the epithelial defect that will form in the cornea. Infiltration and peripheral vascularization, keratinization and conjunctivalization of the cornea surface due to epithelial stem cell failure. End stage disease is characterized by total symblepharon and corneal opacification. So let's see figure 6.18 and 19 for that. So this is a figure 6.18 which is showing the conjunctivitis in the ocular cicatricial pemphigoid. A is showing the early disease with hyperemia and conjunctival fibrosis. B is showing the symblepharon formation. So you can see that there is an adhesion of the bulbar and the palpebral conjunctiva. C is showing the severe fibrosis with fornicial shortening and the symblepharon formation. And D is showing ankyloblephron. So you can see that the eyelid margins are attached together by a skin tag. So this is an ankyloblephron. Systemic features. Systemic features are mucosal involvement is very common and is characterized by the subepidermal blisters, most frequently oral. Severe manifestation include esophageal and laryngeal structure. So you will see the blister in the mucous membrane, especially oral, and it can lead to the formation of structure in the esophagus and larynx. Skin lesions are less common, 25% are present as tense blisters and erosion of the head and neck and groin in extremities. So let's see figure 6.19. It is showing the keratopathy in ocular cicatricial pemphigoid. A is showing epithelial defect. B is showing peripheral vascularization and infiltration. And C is showing keratinization with ankyloblephron. So this is an ankyloblephron and this is a keratinization of the cornea. And D is showing the end stage disease with the corneal opacification. 6.20 is showing mucous membrane pemphigoid. A is showing the oral blister and B is showing the severe skin blisters. So how will you treat the patient with the mucous membrane pemphigoid? Systemic treatment. Systemic treatment is the mainstay of the management. Any detectable inflammatory activity should be suppressed. So basically you have to treat this condition systemically. One of the very important medication that you must remember for the case of OCP is that Dapsone, which is a diamino diphenyl sulfone, is useful first line treatment in patient with the mild to moderate disease. Approximately 70% of the patient respond fairly. It is contraindicated in a glucose 6-phosphate dehydrogenase deficiency. Sulfasalazine is sometimes better tolerated. Antimetabolite, for example, azathioprine, methotrexate, mycophenolate, mofetil, are alternative for mild to moderate disease if Dapsone is contraindicated, ineffective, or poorly tolerated and are suitable for the long-term therapy. Dapsones can be used in the congestion if necessary. Cyclophosphamide may be reserved for severe or refractory cases. So basically you have to treat the immuno hypersensitivity reaction, and you have to use immunomodulators for that as well. Steroid prednisolone 1 to 1.5 milligram per kg are effective for rapid disease control, but adverse effect limit. Long-term use IOP should be monitored. Other measures include intravenous immunoglobulin therapy and rituximab. Remission has been reported with a combination regime. Local treatment, topical mean artificial tear, preferably preservative-free, are an integral part of most regime. Topical steroid, cyclosporin or tacrolimus may be used as an adjunct to the systemic immunosuppressive treatment. Retinoic acid may reduce keratinization. So you must remember what thing reduces the keratinization: retinoic acid. And other, you have to know that OCP is associated with dry eye. You have to treat with lubricants, and there is an immune mediated condition, so you have to give them immunomodulators, that is topical steroids and topical cyclosporin and tacrolimus. Antibiotics when indicated: lead hygiene and low dose oral tetracycline for blepharitis. Subconjunctival mitomycin C and or steroid injection may be used as a temporizing aid, or if the systemic immunosuppression is not possible. Contact lens may be used with caution to protect the cornea from apparent lashes and from dehydration. Reconstructive surgery. So when we do the reconstructive surgery, when you know that there is a symblepharon formation, there is a keratinization, and when there is an ankyloblephron, so in these cases we perform the reconstructive surgery. Reconstructive surgery, preferably under systemic steroid cover, should be considered when active disease is controlled. Apparently eyelashes, so you have to treat the trichiasis. Punctal occlusion to aid tear retention. Basically you occlude the punctum with the punctal plug so that tear do not drain and remain in the eye for the longer period of time for time. Lateral tarsal raphe or botulism toxin induced ptosis may be used to promote healing of the corneal epithelial defect. Entropion repair, conjunctival incision is avoided if possible. Why we do not give the conjunctival incision? Because it can exacerbate the condition of the conjunctiva. Cataract surgery is commonly required. Mucous membrane autografting or amniotic membrane transplantation for conjunctival resurfacing and corneal restoration. Limbal stem cell transfer may be attempted for corneal reepithelialization. Keratoplasty carries a high risk of failure. Lamellar graft may be effective for perforation. Keratoprosthesis may be the only option in the end stage disease. So when there is a corneal opacity, whole of the cornea is going to be involved. So in this case, keratoplasty is not a procedure of choice. You must go to the keratoprosthesis if there is a useful image in the back of the retina. Keratoprosthesis, so you can see figure 6.1 is showing the keratoprosthesis for severe conjunctival and corneal scarring. Next is a Steven Johnson syndrome or toxic epidermal necrolysis Lyell syndrome. So basically, SGS is a very important disease entity in which the antibodies are formed against the in which the antibodies are when a patient react to its to some kind of medication that he ingests. Introduction. The term Steven Johnson syndrome and erythema multiforme major have historically been used synonymously. However, it is now believed that erythema multiforme without the major is a distinct disease, milder and recurrent with somewhat dissimilar clinical feature. So, firstly, there was thinking that SGS and erythema multiforme major is the same disease, but now it is considered that they are two different kind of disease, which is usually erythema, which is usually milder and recurrent form. Toxic epidermal necrolysis 10 or Lyell syndrome is a severe variant of SGS. So when a SGS patient present very severely, we call it 10 syndrome. SGS or 10 patient tend to be young adults, although other groups may be affected. The condition involves a cell-mediated delayed hypersensitivity reaction, usually related to a drug exposure. So, a hypersensitivity reaction that occur due to the drug exposure, but it is not a one drug. It can be due to other kinds of drug as well. A wide range of medication have been incriminated, including antibiotics, especially sulfonamides and trimethoprim, analgesics including paracetamol, acetaminophen, nevirapine, widely prescribed as a part of combination therapy for HIV infection, cold remedies and anticonvulsant, infection due to microorganisms such as mycoplasma pneumoniae and HSV, and some cancers have also been implicated. So you know that the medicine is affected, but you must know that organisms are also associated with such kind of disease. Uh, because symptoms often take weeks to develop, in many cases the precipitant cannot be identified. Mortality overall is around 5% in SGS. Death is commonly due to infection that is considerably high intense. So what are the ocular features? So there will be obviously ocular feature and there will be the systemic features as well. So we will discuss it. In the acute stage, they are often practical obstacle to a standard slit lamp examination, as the patient may be bedridden and undergoing barrier nursing. A portable slit lamp may be useful. So such patient need a very high care because they are having a blisters, and they are having rashes, and they are more prone to infection, so they are treated like a burn like patient. So they need to be in a careful monitoring, so and no with a very good hygiene, and they are usually bedridden. Symptoms. Acute ocular symptoms may include redness, mild and severe grittiness, photophobia, watering, and blurring. Acute signs. Acute signs are there. Acute signs and there are late signs. Acute signs are the patient will present with like conjunctivitis type features, and the chronic sign will be that there will be the scarring of the conjunctiva that will occur. So acute signs are the hemorrhagic crusting of the lid margin is characteristic. Skin lesion may be confluent, and it is often difficult for the examiner to open the eyes without causing a marked discomfort. So there will be the crusting of the lid margin. Papillary conjunctivitis, which can be ranged from mild, transient, and self-limiting to severe. Conjunctival membranes and pseudomembranes, severe hyperemia, hemorrhage, blister, and patchy infarction. Keratopathy, a spectrum of lesion from punctate erosions to a large epithelial defects, secondary bacterial keratitis, and occasionally perforation. Iritis is not infrequent, and panophthalmitis have been reported. So we will see figure 6.22 for that. So let's look at the figure 6.22. So you can see the ocular features of Steven Johnson syndrome. A is showing the hemorrhagic lid crusting, B is showing acute conjunctivitis, C is showing the pseudomembrane formation, D is showing the conjunctival scarring, and E is showing keratinization with severe lid margin involvement, and F is showing the corneal keratinization. So, what is the late signs? Conjunctival cicatrization with fornical shortening and similar formation. So, whenever the conjunctiva will be scarred, there will be like fornical shortening, similar frown formation, keratinization of the conjunctiva, and there can be the eyelid complication like ankyloblephron, entropion, trichiasis. These are all the complications that can occur with it. Keratinization of the conjunctiva and the lid margin, sometimes with abrasive plaque formation. Eyelid complication include cicatricial entropion, trichiasis, metaplastic lashes, and ankyloblephron. Keratopathy includes scarring and vascularization and keratinization as a result of primary inflammation on or infection, as well as cicatricial entropion and aberrant lashes. Watery eyes due to fibrosis of the lacrimal puncta. Dry eyes may also occur as a result of fibrosis of lacrimal gland, ductule, and conjunctival metaplasia with loss of core blood cells. Systemic features. So obviously there will be the systemic features with the SGS as well. Skin biopsy may help to establish the diagnosis, but is rarely necessary. Symptoms: flu-like symptoms which can be severe may last up to 14 days before the appearance of the lesion. In many cases, the patient is very ill and the hospitalization is required. Symptoms of the systemic mucosal involvement include nasal pain, discharge, pain on micturition, diarrhea, cough, shortness of breath, and pain on eating and drinking. So, as the whole of the mucous membrane is affected, so you will have a pain while eating and drinking, you will have a pain on micturition, you will have a cough, you will have shortness of breath, diarrhea. So what are the signs? Mucus involvement is characteristic by blistering and hemorrhagic crusting of the lips. The blisters may also involve the tongue, oropharynx, nasal mucosa, and occasionally the genitalia. Small purpuric vesicular hemorrhagic or necrotic skin lesion involving the extremities, face, and trunk. These are usually transient but may be widespread. Healing usually occur within 1 to 4 weeks, leaving a pigmented scar. Widespread slowing of the epidermis is uncommon. Target lesions showing the clear classic three zones are now viewed as a characteristic of the erythema multiforme rather than SJS and 10. So let's see figure 6.23. So this is the hemorrhagic crusting of the lip, and B is showing the excoriated skin. So what are you going to see? You are going to see the blisters all over the body, and severe rashes can be seen on the face and trunk, and uh, which will be like a vesicular, hemorrhagic, and necrotic skin. So how will you treat? So you will treat it systemically, and you will treat the ocular complications as well. First we will go through the ocular systemic treatment of it. So first of most important is you have to remove the precipitant. What causes the SGS? You must remove that cause. Removal of the precipitant, if possible, such as discontinuation of the drug and the treatment of suspected infection. General supportive measures include such as maintenance of the adequate hydration, electrolyte imbalance, and nutrition, especially protein replacement, are critical. Because the person cannot eat and drink properly and there is a loss of blister formation, so you must keep the hydration and electrolyte balance. Management in a specialist burn unit should reduce the chance of infection when the extent of the skin involvement is substantial. Systemic steroids remain controversial. They are reported of increased mortality in older papers, but later research has raised the possibility that early short-term high-dose intravenous treatment may improve outcome. Other immunosuppressants, including cyclosporin, azathioprine, cyclophosphamide, and intravenous immunoglobulin, may be considered in selected cases but are controversial, and controlled trials are lacking. Systemic antibiotics may be given, such as prophylaxis against the skin or other systemic infection, avoiding those known to be the high risk of precipitating SGS and 10. So you may give antibiotics, but usually what causes the SGS, you do not give such kind of medication. So, how will you treat the ocular leaf? Acute disease daily reviews advisable initially in most patients to check the corneas and exclude similar front formation. So, one thing you must be very careful in this type of patient is that you have to not let the similar front formation to happen. What you can do is you can basically apply a lot of lubricants in the eye, and you can give a lens that prevents the similar front formation, and there are other certain measures that you can give. Topical lubricants are used as frequently as necessary. For example, hypromellose 0.3% preservative free up to early high viscosity ointment during sleep. Prevention of the corneal exposure, for example, moisture chamber, gel pads if mechanically ventilated. Topical steroid may be used for iritis and for conjunctival inflammation, though a benefit for the latter has not been demonstrated conclusively. Topical cycloplegics, for example, atropine 1% once or twice daily may improve comfort. Lysis of a developing symblepharon with a sterile glass rod or damp cotton bud. So you can ask the patient that you can use a glass rod, and you can try if there is a you can see that eyelids are attaching together. You can use a glass rod to lyse the symblephra. A scleral ring consisting of a large haptic lens may help to prevent this symblephron formation. So this is a scleral ring that is present in the whole of the sclera, which is preventing the formation of the symblephra because of the non-contact between the palpebral and the bulbar conjunctiva. Pseudomembrane and membrane peeling can be considered, although the benefit is unproven. Treatment of the acute corneal problems such as bacterial keratitis, conjunctival swabs should be considered for prophylactic culture. IOP monitoring may be prudent using a portable tonometry if necessary. Chronic disease. Adequate lubrication, including punctal occlusion if required. Topical transretinoic acid 0.01% or 0.025% may reserve keratinization. As I told you earlier, that the retinoic acid is very important in the case of the keratinization. Treatment of aberrant lashes. Bandage contact lens, typically gas permeable. Scleral lenses to maintain surface moisture, protect the cornea from aberrant lashes, and address irregular astigmatism. Mucous membrane grafting, for example, buccal mucosa autograft for pharyngeal reconstruction. Corneal rehabilitation may involve superficial keratectomy for keratinization. Lamellar corneal grafting for superficial scouring, prefer to penetrating keratoplasty. Amniotic membrane grafting, limbal stem cell transplantation, and keratoprosthesis implantation in an end stage disease. Next is a graft versus host disease. So what is a graft versus host disease is basically in a patient that undergo the transplantation. So in this case, when the eyes are affected, it is called the graft versus host disease. Ocular graft versus host disease occur in a patient who have undergone allogenic hematological stem cell transplantation, an operation that is undertaken on an estimated 25,000 individuals annually worldwide. It can occur in a patient who have acute or chronic graft versus host disease, although it is more frequently seen in the chronic form. Clinically, it manifests in a similar fashion to the Steven-Johnson syndrome. Ocular manifestation develop in 40 to 60% of the patient after the stem cell transplantation and can lead to significant ocular surface consequences. So basically, a patient who is undergoing the stem cell transplantation for some hematological problem and the eyes are involved, it is called the graft versus host disease. So what are the ocular features? Dry eye syndrome, keratoconjunctivitis sicca, conjunctival hyperemia with pseudomembrane and membrane formation, chronic inflammation leading to cicatricial changes in the conjunctiva and occasionally in tropion formation, Corneal manifestation including punctate epithelial keratopathy, marginal keratitis, and filamentary keratitis. Severe disease can lead to corneal erosion, thinning, ulceration, and possible perforation. So, how will you treat? You will treat it. The artificial tears can be helpful. Topical cyclosporin 0.5% is the mainstay of the treatment. Systemic treatment does not necessarily improve the ocular symptoms and signs. Oral steroid are often used. So these are not this was not so important, very important topic, but you must know about that there is a condition known as graft versus host disease. So that's it for the conjunctiva part 5. See you in the next lecture.